Welcome, everyone. Good morning, good afternoon, good evening. My name is Catherine Duggan. I'm the Chief Executive Officer of FIP, and I welcome you today to this episode of Coffee with FIP, a podcast-style mini-series designed to provide pharmacy professionals around the world with a dynamic, interactive platform for informal, evidence-based and CPD-informed and aligned discussions on key and timely topics in pharmacy. These topics reflect FIP's strategic priorities and programs. Just a note that the podcasts themselves, the views and opinions expressed in the episode don't necessarily represent FIP's official position unless explicitly stated. Instead, they're here to give us some wider perspectives. The episode today is planned around the theme Resisting Resistance. Pharmacists are champions leading the AMR response. And with me today, I am delighted to welcome Gabriella Hardy-Gould, who's a pharmacist volunteer on the AMS training programme at King's Global Health Partnership in Sierra Leone, Department of Population Health Sciences. She's also a senior clinical pharmacist for antimicrobial stewardship, University College London Hospitals NHS Foundation Trust. Hello, Gabby. Would you tell us a little bit about yourself?
Great. Thank you so much, Catherine. Well, I am, as you said, a clinical hospital pharmacist by background, and I'm currently working at UCL Hospital. So I can give you a little bit of a background of what I do in my day-to-day role, and then maybe we can talk about how I got into working with King's Global Health Partnerships. So in my current role, I work alongside the lead antimicrobial pharmacist, and I lead the day-to-day delivery of clinical pharmacy services to the OPAT service, which allows patients to be discharged home from hospital on IV antibiotics. I also do a lot of work developing and reviewing antimicrobial guidelines and local policy. I also work closely with microbiologists. We do a lot of work with the allergy service to review patients who have penicillin allergies that are potentially incorrectly labelled. And if they meet the right criteria, then we can give them an oral challenge of penicillin, carefully monitor them. And obviously, patients with an incorrect penicillin allergy can lead to development of kind of antimicrobial resistance. So we also do a lot of participation in consultant-led antimicrobial ward rounds. I attend lots of multidisciplinary team meetings and do education and training, and run a lot of kind of public health awareness raising campaigns in the trust. So that's a bit of a summary of what I do in my current role, because I know a lot of people might not understand what that role means. And then with regards to how I ended up working in Sierra Leone with King's Global Health Partnerships. So at the time I was working at King's Hospital, which is linked to King's Global Health Partnerships. And I was really keen to do something else within my career. So I was looking out for roles, for example, on LinkedIn, there's a humanitarian pharmacy page. And I was kind of looking through different opportunities. And a pharmacist working with King's Global Health Partnerships at the time reached out, called Suzanne Thomas. She'd seen that, I had the kind of relevant experience as I was working in infection at the time. And so I decided to go for it. I'd never been to Africa before, decided to go for the role. It was a 9-month position. And the idea was, the project was called Strengthening Pharmacy Leadership for Antimicrobial Stewardship. So I did the first 9 months of that project.
I think, Gabby, there's much to unpick here, and I think we're going to need you back for other parts of FIP, also as a true role model for many women at early and mid stage of their career who we just want to encourage to take a bit of a chance on an opportunity. Super to hear. So we will have you back. But looking at today and the time that we have together, we want to discuss a little bit more about the focused conversation today. I've got 3 main questions and then I'll sum up, and I'm really keen to hear more from you. So my first question, Gabby, what are the key challenges and misconceptions surrounding antimicrobial use in Sierra Leone? And how can AMS champions effectively address them?
Well, there are quite a number of challenges and misconceptions, as you can imagine. Sierra Leone is a country in West Africa, and it's faced a lot of challenges over the years. And I think those challenges, including civil war, Ebola in 2014, natural disasters, have contributed to it being quite a limited resource setting. And so some of the challenges that we found when we were working there and working with the AMS champions included things like infection burden, things you wouldn't be surprised by. So, quite a high level of disease, HIV, tuberculosis, malaria, parasitic infections, lack of clean water and sanitation. We also had limited diagnostic tests. So we didn't have any microbiology labs in the hospital we were working in. In Freetown, one of the main hospitals, there was supposed to be a lab that was being built, but that had been delayed. So we didn't have any cultures and sensitivities coming out of that. And I think that had contributed to a lack of local and up-to-date guidelines. So it's quite hard to police antimicrobial stewardship without local guidelines that reflect kind of the population there. Other challenges that we faced were things like freely available antimicrobials without prescription being sold by unlicensed community pharmacies or drug peddlers in markets or on the buses. It wasn't always well regulated, even though the Pharmaceutical Society do have lots of laws and legislation. And then we also had a problem with drug shortages or lack of availability of drugs. And it was estimated that 1 in 10 medications in Sierra Leone were kind of falsified or substandard. So those were some of the challenges. There were also a lot of misconceptions. I think these are really interesting to talk about, actually. So lots of antimicrobials were being used to treat any ailment, as it has been in the UK for a long time. People back in the day thought you could use antibiotics for coughs and colds. But in Sierra Leone, when I spoke to some of the community pharmacists we were working with, a lot of the women will use antimicrobials after having sex because they believe it cleans their system, or also women using antimicrobials during menstruation. And I think that these are very embedded. And so when we had conversations with people, when the pharmacists were kind of challenging prescribing over the counter, people were really shocked. And these beliefs were not, just in, more rural areas, for example. They were very much countrywide. And so I think AMS champions in general can kind of counteract some of these misconceptions and challenges by doing a number of things. For example, in our case, the AMS champions went into community pharmacies. They did a lot of community-based awareness raising. So going into schools, talking on national radio and TV, shouting as loud as they possibly could about this, going to where the drug peddlers were selling and standing next to them, kind of counteracting some of the information these drug peddlers were giving out. Also, when they were kind of going into schools, for example, they would talk about the risks of falsified medicines or the unlicensed community pharmacies and how to spot potentially some of these risks of this. And then also things like talking about infection prevention in community. So just basics like hand washing, just other ways of kind of avoiding infection, when to isolate, when to see a doctor. And then when we broke it down, so the training project that we did, there were 3 hospitals, there were 3 community pharmacies. So when we focused on the community pharmacists, they did a lot of training within pharmacies to talk to pharmacists about how to counsel patients on antimicrobials properly. And then with regards to kind of wider ways that antimicrobial champions can challenge, we actually worked with the Pharmaceutical Society to identify areas of the educational program that needed updating or changing to include AMS. So when you've got all these pharmacy students that are coming through the system, they actually realized there wasn't enough antimicrobial stewardship. So they developed continuous professional development, so CPD programs, specifically for these pharmacy students, so that they knew that every single new pharmacist would at least have some AMS training. And then when it came to the hospital-focused AMS champions, they did a lot of education and training. So for the doctors, the nurses, other pharmacists, There was also a lot of liaising with the infection prevention control team, because AMS champions, I think they're really well placed to kind of identify other people in the hospital who can then facilitate further kind of passing on of the message. After I left, I spent 9 months in country and then handed over to another pharmacist. And they were able to set up a national AMS pharmacy forum. And this was with the pharmacy leads from each of the hospitals. And the view from this was to try and develop a bit more visibility from the ministry and the policymakers, because I think ultimately you can shout as much as you want about it, but some of the issues kind of come down to higher level policy making. So that's a kind of summary of some of the things. I could talk about it forever.
Well, this is amazing. I think you've really touched on things that other countries could look at. Definitely. You can't have a one size fits all. We can't go in and just apply good practice, Gabby. We really have to gain a sense of what the culture is, the context, and then some of the beliefs. And I think a lot of what you're doing here is really transferable to our work on vaccine hesitancy, for example. So a lot of learning for FIP from your helpful insights. Gabby, looking at the time, we are trying to do this in quite a concise way today. I'm going to move on to the next question, and you have touched on this, so I think it'll be very familiar to you. How does mentorship and local engagement contribute to the success of AMS initiatives in resource limited settings? Bearing in mind, Gabby, I think all of us think we're working in resource limited settings, so it's very transferable. Thank you.
Thank you. Yes, I think the one-to-one mentorship in the programme and the local engagement, so having kind of in-country volunteers was incredibly important. I think for me, being in country meant that I was able to spend a bit of time building rapport, beginning to understand the nuances of the culture and the workplace. And I spent 1 to 2 hours with each pharmacist every week. Although some of these pharmacists were early career, some were very newly qualified, others were chief pharmacists of hospitals, some were military generals, so really had to adapt the mentorship, kind of what they needed from it. Most of the pharmacists had very good levels of kind of book knowledge, but they needed support in applying the knowledge to clinical scenarios. And there were very much varying levels of leadership and management. So in this setting, I think the mentorship really provided a structured support, leadership, a clinical sounding board. One of the challenges that was in Sierra Leone, but I'm sure would is the case in many different places, hierarchy was a big challenge. So I was able to support champions in approaching senior management when navigating a change of practice. So in hospital, we supported a change in practice through collecting data. We did point prevalence surveys and then presented this results to the hospital board. I think mentoring also allowed, I was able to support difficult conversations. So there were some pharmacists in community pharmacies who were in a slightly challenging position where they wanted to refuse the sale of antimicrobials, but then they were basically reducing the amount of money that the community pharmacy was making. So that's a challenging conversation to have. And we were thinking of what the workarounds are about that. So as a mentor, you can really support more wider than just kind of telling someone about AMS. I think you can really support those challenges in the workplace. I think I found the pharmacists to be incredibly passionate. They were also quite stretched. So lots of them had lots of different jobs and not that much time, which is the case in lots of different parts of the world. But we were able to support the timelines and the progress and kind of continue the momentum through the accountability that mentorship brings.
Again, a lot of transferable messages there. And I think this is the beauty of having a podcast like this, Gabby, with someone who comes from one country and learns in another. You can see a lot of these issues are similar, but you have to be context driven, don't you? My third question for you then is, in what ways do you believe that an AMS program can adapt to systemic limitations such as lack of diagnostics, medication shortages? You mentioned the systemic substandard and falsified medicines that you encountered while we're still promoting and supporting sustainable behavioural change.
I think that in order to adapt to the systemic limitations, I think it's first important to really understand the setting you're in. What are those limitations? In our situation, it was lack of diagnostics and lack of cultures and sensitivities. You know, when I first entered the country and I went on ward rounds and I was really trying to embed myself in the culture, I was just struggling because I was suddenly in a place where, you know, you couldn't just ask the microbiologist, oh, okay, what's this wound? What are the cultures? What are the sensitivities? Tell me what to prescribe or whatever. You couldn't do that. So I think it was being flexible. And in this case, we had a look at it and we thought, how can we develop sustainable behavioural change? And this was very much done in partnership with a Sierra Leonean pharmacist. So asking them, what are your ideas? How do you think that we can really make a change? And there were some fantastic ideas, and a lot of it was, as I mentioned earlier, about doing point prevalence surveys, getting data. And I think with point prevalence surveys, you can actually compare how your hospital or how your country is doing to neighbouring countries. So we were able to kind of gather that information and then spur on the leadership in the different hospitals, because they realised actually this is a bit of a competitive thing. And then that gained a bit of national engagement. And as I said, we set up antimicrobial stewardship committees in 3 hospitals, including a paediatric hospital. And that was I think that is the first paediatric hospital in West Africa with an antimicrobial stewardship committee. So antimicrobial stewardship committee will have lots of different multidisciplinary members involved. It will have senior leadership involved as well. So I think that was one way that we developed that's very sustainable in terms of behavioural change. Also, public awareness raising campaigns, as we said, developing this AMS champion model meant that we had AMS champions from the previous cycle training and supporting the current ones. And then all of these pharmacists kind of going out now have a massive interest in AMS. You know, they're publishing papers and doing a lot of education and training sessions. So I think that, you know, you definitely have to adapt to what you have.
Yeah, it's great. And I think those examples are very well thought through. Congratulations for creating so many firsts. I love it when you see a bit of competitive professionalism emerging. And I think it's a much better way to encourage sustainable practice by best practice rather than by sticks of poor practice. So I think this is a really, really good way of doing it. I think Gabby will definitely have you back. Now, delightful. Any final words, Gabby, before I close the podcast for our listeners today?
Yes, I think that anyone that's considering taking a kind of sideways step or doing something a bit different in their career, I would highly encourage them to do so. It's massively benefited me, that experience, in terms of the things that I've learned. You can learn so much from other cultures, and I would highly encourage anyone to do that. It's opened up a lot of doors for me. So that is what I would say.
Well, you've said it very, very well, and we welcome you as part of our FIP family. It's one of the joys that being part of FIP brings us all, that we have got that family of different cultures and different experiences to learn from. And it's amazing what friendships you can make along the way as well. Thanks so much, Gabby. I have to say, busy people doing busy things, making time for us makes us super grateful. And I want to say a big thank you to everyone who's been listening to this Coffee with FIP episode. And please check out the FIP website for more resources and episodes as they emerge. And as I say to everybody, this is not the last time you will be hearing from Gabby. Thanks a million, Gabby, and good luck.
Thank you so much.